we're going to take a little tour of what's going on in healthcare, not just the healthcare insurance industry, and I'll give you a perspective that you probably wouldn't expect to get from a health insurance executive. But as Peter mentioned, in 1979 I had flunked out of college for the second time with a 1.79 grade point average at Wayne State University, and I was assembling rear axle differentials for the Mercury Bobcat at Ford Motor Company and making $62,000 a year, and I thought that was a pretty good job. And it was a 7 to 3 shift and then weekends. A friend of mine suggested that I get my bachelor's degree, so I went the easiest route, which is accounting, because I was a math major. A friend of mine then was studying for the GMATs, and I placed in the top percentile in the country and got offers from universities like Stanford to go to school. Cornell was the one I chose because it was cheapest. Somehow I've ended up in the healthcare industry. I've had one resume. I've never looked for a job. And every time the phone has rang because somebody needed my help. I fix broken things and build new things. I do not make the trains run on time. That's not my specialty. So my career has been peppered with taking companies public and selling organizations and fixing broken companies. And I don't think that I could be better prepared at a time like this in the health insurance industry and the healthcare industry to fix an industry that really is not an industry, is really not a system. And given my personal experiences were briefly described, I've seen it work from both sides, inside and out, and it really doesn't work well. And I'm here to share with you a larger vision of what it could be and some of our experiences that we're going through at Aetna. Aetna built this as the very first job when we were losing $1 million a day in 2001. And people say, why are you creating values? Well, we need an organizing principle around which we can rally 44,000 employees, which was how much money we were losing every hour. $44,000 an hour, 24 by 7 by 52. So it was like every employee reaching into the till, pulling $1 out and burning it every hour of the day. And so we organized them around these sets of principles, which is meant to put the people who use our services at the center of everything we do and to organize their thinking when there wasn't someone around to tell them what to do. So one of the things I like to focus on, and particularly in this kind of talk, is inspiration. We really do inspire one another in what we do, both personally and professionally. We are a LEED certified organization. We have given away $425 million as a company through our foundation in our history. We have over 1 million hours per every 3 years from our employees in voluntary service to the communities that serve, and they contribute with our matching $9 million a year to their charities across the country and around the world. And so our view is really to inspire one another, not only in what we do in work every day, but what we do and how we represent ourselves to the public. So this was an article by Zeke Emanuel in the New York Times talking about the end of insurance companies by 2020. And I would argue that the insurance companies that we know today will end. It'll probably be sooner than 2020, but we're not going away. So I'll paraphrase Mark Twain, who's from Hartford, Connecticut, where we are headquartered. You know, the rumors of our demise is greatly exaggerated. Number one, we have a lot of capital. Number two, we're in the center of all the data. And number three, for those of us who think about our role differently and are willing to give up control to get power, we can actually have a huge influence on healthcare here and around the world. So we've, as a company, been using somebody from the Stern School at New York University. His name's Luke Williams. And he has this book called Disrupt. And it's taking things that you would normally assume are cliches about what we do every day, givens, and turning them on their head. And the one example he used outside of healthcare was, we all believe that socks should be sold in pairs, right? We got 2 feet. And they should match. How many people in here have young teenage children, daughters particularly, right? And what do? They buy Little Mismatch, 3 socks in a bunch, and they're all different. And I'm kind of jealous because I like to wear different colored socks, and they don't have my size. I went and checked. But That's a great idea. We challenged an assumption that said socks always should be sold in pairs. He calls them cliches. So let me give you a few cliches about the health insurance industry. Healthcare costs always go up, right? Inexorable, can't stop it. Healthy people are better risk than sick people, right? And then waste in healthcare system is unavoidable. So these are three cliches that our team came up with. And we chose to challenge a couple of them, and I'll give you an example. Aetna's been around for 160 years. We have been assessing, underwriting, and pricing risk for 160 years. The formulas we use are 160 years old. I believe that some of our actuaries started with the company in 1851. So of course we know how to do that. What's changed over the years? What we assess, underwrite, and price. So here are some hypotheses. What if we keep healthcare costs flat or even lower them? What if the sickest populations were actually the best risk? And what if we could pay for the uninsured by reducing waste, including paying back half the US $16 trillion worth of debt? Those are the hypotheses that we have challenged. Sicker people are better to take care of, and we can pay back half the nation's debt over the next decade. So what we have is a convergence of a few things, all created by the Affordable Care Act. So for those of you who are wondering why the president was focused on the Affordable Care Act when the economy was headed to ruin, 75% of the next $10 trillion worth of debt in this nation will be driven by Medicare and Medicaid. If you add Social Security, it's 150%. If we solved waste in the healthcare system, we would reduce the 2013 deficit, which is $910 million, by 80%. So healthcare is our problem with the economy. We call them entitlements because it sounds better when we distance them from people, but it's really about healthcare. So the Affordable Care Act has created an action-forcing event. It causes people to think differently about how we solve the problem. And based on technology that's always been around and some huge economic shifts that have occurred in the healthcare system over the last 5 to 10 years, we believe that the opportunity for innovation is now. So let's talk about the economic side of this. This is the waste in the healthcare system in 2009, $750 billion in 2009 alone. This was put together by the Institutes of Medicine, so it's a bunch of doctors. It wasn't insurance executives sitting around looking for a big number. These were physicians who said that we waste $750 billion, or approximately 30% of healthcare spending. This year it's $2.7 trillion, so call it $800 billion. If we fix this problem, in a decade we pay back $8 trillion, half the US deficit. If we fix just half of it, we do what Simpson Bowles did with their recommendation to the president and to Congress. And if we fix just 20% of it, we pay for the Affordable Care Act without raising anyone's taxes. So when we looked at what we assess, underwrite, and price, this is the problem. And we're part of that problem. We have 44% inefficient delivery of care and unnecessary services. We have fraud, waste, and abuse. And then we have administrative costs, all created by a system that tries to track each individual use. 30%, 25% of that is insurance administrative costs, hospital, physician, and other administrative costs. So what do we do to make the system better? Well, we have the technology today. And I'll talk about that in a few minutes. Here's the other shift. Now, for all of you who worry about seeing a foreign medical grad as a physician, your worries are about to be over, because they're not going to stay here anymore. They'll get educated here, but they're going to go back to their countries. China's 160,000 physicians short. We'll be 100,000 physicians short. India is short of physicians. Everywhere around the world is short of physicians. And as those economies emerge and create middle classes that have higher expectations around social safety nets, they're going to be able to afford to keep those physicians, and we won't have them. And we'll have an even bigger shortage. Secondly, physicians, the economics of independent physician practice are broken. Insurance companies run on underwriting margin, hospitals run on revenue, and doctors' offices run on cash. And if you've ever run a cash business, when you're trying to take risk, it blows up on you and you go out of business. So over the last 7 to 10 years, physicians have gone from 25% institutional owned to over 70% institutional owned. If you run this number out another 3 years, it's going to be 85% of all the practices in the United States, and over 2/3 of all the physicians in the United States will be working in an institutional setting. The second thing that's happening, which is very interesting, is that a lot of these institutional settings are now being run by physicians. So there's a fundamental shift in the way they think about how to run the healthcare system. And then here is a graph of the single largest tax increase on the American public in the history of the United States. The bars on the bottom are the underpayment by the government for Medicare and Medicaid. If you look at that number, it's way off in 2009 and 2010. It's going even further with the most recent budget proposal in reducing Medicare and Medicaid reimbursement at the states. And who has paid for that? You, through your commercial premiums at your employed workplace. Or, if you're lucky enough to be in the individual insurance market, through your individual insurance payments. Because in the commercial marketplace today, the average margin, now this, one big assumption. This assumes that the healthcare system costs are appropriate. Big assumption, but just work with me on this. In the commercial market, it's 140%. So there's a 40% margin in the commercial market from hospitals and doctors to cover the underpayment of the government system. That is a tax, that's cost shift, but it's a tax increase. Because the government is underpaying, and you're turning around and paying that and covering that expense. The hospitals have figured out that what happens when you keep doing this, at least the forward-thinking hospitals, is if you keep running this line out long enough, what also is happening is that more people are going in government programs, Medicare and Medicaid. 100,000 people every day retiring. So if you keep running that out and you don't do something about it, all of a sudden you're getting paid solely by the government, you're getting paid way under your cost structure. So let's talk about the technology side. The technology side hit me really hard one day when I was standing at Macy's in New York because my daughter, who is an editor at Gawker in New York, and sends me an apology every time they write about me, secretly. When she said I had to have this sweater, and here is it, it's at Macy's on this rack in this department. So I took out my Droid and I barcode scanned it, and up popped Google Shopper, and it said here's who made it and here's how much it costs. And then it told me all the other stores near me that had it, and I picked the cheapest one, and up popped Google Maps, and I got directions plus a phone number that I could call and have them hold it for me. And that all took 45 seconds. So I bought 2 sweaters. One for my daughter, and the other one I brought to work. And I started showing everybody at work, we need this for healthcare. So the technology I'm about to talk about isn't the genetic stuff or all the body devices, implants, and everything we can do. And I can spend time talking about that in the Q&A. We're working with all of those. I'm going to talk about the very simplest technology that we have available in every other aspect of our life. Why shouldn't the healthcare system work for us? Why shouldn't we manage our healthcare versus having to use the healthcare system? So here are some of the internet and mobile adoption users around the United States. I just returned from China, where we've done a joint venture, and I'll talk about that in a minute, with the Binhai New area in Tianjin. And in China, they have 600 mobile phones in the marketplace. And these are just smartphone subscribers, 270 million, almost as many people as there are in the United States. So this adoption is dramatically increasing everywhere around the world. And our problem here in the United States is that every time we build an app for the healthcare system, we have to force our members to use it because they want to use the phone. And it's like everybody checks out when they enter the healthcare system and puts all their technology away and, and wanders around the system like the Walking Dead. And what we're finding in places like China and in India, all people have are smartphones and mobile phones. And so you don't have to re-educate people about how to use them because that's all they use. That's how they access the system today. Aetna, for the last 7 years, has been buying technology. And every time we buy them, the analysts say, what are you doing? Why are you wasting your time on stuff like this? Well, today we now have the single best and the only full technology stack that allows us to create what I call health plan in a box. We put hospitals and health systems in our business. So we bought a company called Medicity, which is a health information exchange, now has 29.8% of the US marketplace wired together. They have a grid technology called iNex, which shares the computing power of the grid. We're real-time node encrypted, so each device is a node. And we now have an SDK, software development kit, and APIs on a public website for everyone to write apps, which can be downloaded from the iNex platform to physician and hospitals' desktops to get healthcare technology much cheaper than they get it from their legacy vendors today. All in an attempt to disrupt or underprice that marketplace. We have Active Health, which is a clinical decision support system. iTriage, which is the device that you will now be able to use in the healthcare system to get that office visit and appointment whenever you want. CarePass, which connects across the platform all of your apps that you use for healthcare, Fitbit, your running program, your dietary program, all into one application that shares the data, all connected to our own intellectual property. What have we done? 40 systems around the United States are either in letter of intent or contracting with us to put this technology stack in to connect them with their doctors and with every other hospital they do business with to create an insurance mechanism to manage risk. And what we become is sort of the intelligence inside their organizations to be able to power their systems and give them the intellectual property to manage that risk. We have made it payer agnostic. They can use it for all of our competitors, and we allow them to white label it and put their own products in the marketplace. In the end, when public exchanges come up, and we can expect them some in 2014, but it's going to roll out over a number of years, we would rather have Banner Health System and their product on the exchange than Aetna. Banner powered by Medicity. Innova powered by Active Health, because we redefine keeping my doctor and my hospital. And so it becomes a different kind of healthcare system. And all we are is the intellectual property inside the system helping them manage it, using our risk-based capital to help support their overall risk management. So this is a very different role for an insurance company. We don't sell members anymore, we convert patients. And by the way, the sick ones are the most profitable. So if you think this conversation is strange, have it with all your actuaries sitting in the room and they're going, wait a minute, you want us to we want the sick ones. We want to be the bad bank. Because if we get paid for the risk, we can manage it more effectively using this technology. So imagine a world where payers manage health instead of risk, because risk is sort of second nature to us. And so this is our model. Go back to the 70s, if any of you can remember those. Bell bottoms, right, long hair, little skinny glasses. And we used to have people back then called health systems planners. And health systems planners used to look at the demography, the disease burden, and the economic and environmental and societal trends, and they used to decide whether or not a hospital could buy a new piece of technology. It was called certificate of need. But we decided that was just too much of a hassle and a waste in the system, so we got rid of all of our health systems planners. We sent them off somewhere. They became hospital strategic planners. And what we did is we lost our opportunity to do true population health management. So what if we actually looked at the demography, disease burden, the economic, societal, cultural trends of a community and said, where should our hospitals be? Where should our practices be? What kind of doctors, clinicians, nurse practitioners, massage therapists, acupuncturists should we have in the system? All with the goal of improving the productivity of the population, allowing them to be more economically viable and happy as a definition for health. So that's what this is. Now, this will happen soon, but not here in the United States. This is a shot I took from a car 3 weeks ago. This is the Binhai New area of Tianjin, China, where this is one of 6 different pods of 20 to 30 skyscrapers, all 50 to 100 stories, all going up at the same time. They're all empty. So you just keep driving around. They planted 373 million new mature trees to improve the environment, and it looks a bit like Manhattan when you get close enough to it because they want it to be China's Silicon Valley. And they want to attract 4.5 to 6 million multinationals to this community, and they want to have a healthcare system for the future. Now, why do they need a healthcare system? Well, China's savings rate's 50%, a third of which goes to first for education, because education ends early. Second, to healthcare, because they only cover 240 RMB, which is 40 US dollars. And healthcare, everybody's insured up to 240 US dollars. And then thirdly, for housing. And with 53% of the population now in cities, their imports required to support that population are overwhelming their exports. And so they need to create, as part of the 12th five-year plan, an inclusive economy focused on moderate prosperity, or a domestic economy. And the only way to do that is to reduce the savings rate. And the only way to reduce the savings rate is to create a safety net in healthcare and education. And oh, by the way, if the healthcare system were designed properly, it could be an economic engine that improves the productivity, financial viability, creates a service industry, low carbon footprint, that could then support their domestic economy. That's what they want. We signed a joint venture deal with Tianjin High Tech 3 weeks ago, March 25th, to help them build that healthcare system as a future, as a pilot, so that they can consider it for the rest of the China. It will be the largest healthcare systems project China's ever invested in, 300 million RMB. And so this model is really built around that population health management model I showed you, creating a happier population. Now, it's not all altruistic. It's a political problem for them as well, unless they get this problem solved. And what they don't want, as the finance minister told me in one of my meetings with him, was we do not want the US healthcare system because in 40 years we can't afford it. Now, China, little known to most people, will have more people as a percentage of the population over 65 by 2030 than any other country in the world. It'll be 29%. Germany's the highest with 27%. Currently, they have 97.5 million diabetics. We have 27 million in the United States. So they already have this problem. They just don't know it. And quite frankly, people just don't get the care. One of our hottest selling products in China is for the high net worth individuals to be evacuated out of China for tertiary and quaternary care. They will pay anything for that policy. So this is where the future is going to start. And as I like to say, we think about the states and here in the US as the laboratory for democracy. The laboratory for the new healthcare system is going to happen in places like China and India, Riyadh, Qatar, all places where we're talking about this kind of project as a company. Not insurance. We're not underwriting anything here. We're building a healthcare system that can be underwritten when the middle class gets to a point where we have enough economic personal disposable income for them to buy insurance. And how about a world where the sick can find the care they need in the palm of their hand? So we bought this company called iTriage, and it's free. You can download it. And we've had over 9 million downloads. It has a symptom checker. You can get appointments with your provider. You can send them your health data out of your personal health record. And you can get follow-ups from the physician. And what we'll have here in another month or so when we launch is the ability to buy care on the spot market basis that's vacant near you. Think of it as open table for healthcare. Lab tests, x-rays, flu shots, office visits. And we'll buy it, and then we'll resell it for convenience. So what we want to do with this piece of technology is we want to redefine quality as convenience. Because for most people that use the healthcare system today, one of the biggest compliance issues is it's too hard to get it done. I've got to work my life around the healthcare system instead of taking care of my health on my terms. And this piece of technology is going to do that. So our whole move is to make it easier. And as one of your professors, B.J. Fogg here at Stanford, has talked about is, you need to make it easier. You don't have to compel people. And I can have a conversation with any one of you about diabetes and what it'll do to you if you keep eating and living the lifestyle you're living. And we can talk about what that means for you when you're 30 years older. And when I talk to even people in their 20s, they go, yeah, that's great. Mañana. But if we make it easy to do, we can have an impact. Things like my upband that I'm wearing. And so that gets connected to, how about a world where the healthy can manage their wellness and health in one spot? And so we'll launch as well CarePass, which will connect all of your apps to one data set. So when you update one piece of data in any of your other apps, it updates the rest of your apps. Again, easy, so that you can track it. So this is the future of healthcare, where the consumer takes control of the healthcare system, not the insurance company, not the hospital, not the doctor. That will be the difference. Where you are in charge of your health versus trying to make the healthcare system work for you. And none of it is bleeding edge technology, right? None of it. So it's really about mass customization for the individual using population health, making people more economically viable and happier. Excuse me. So the healthcare system is going to change because the Affordable Care Act has created an action-forcing event. In October of 2013, all the fundamentals of the health insurance industry will change. That will ripple through the healthcare system, doctors, hospitals, patients, and it'll all be up for grabs. As I said to our team, we have 300 full-time equivalents working on this every day inside our organization. We took our brightest people and put them in a project management office. I said to them, we need to be compliant with the new law, but we've got to find all the ponies in that stuff because there's going to be bunches of ponies. And when people fail, we want to be on the other end of it to consolidate and make the system better. So the Affordable Care Act is driving this. The system will change. It's really about the consumer and their own access to the healthcare system, managing their health versus managing their health care. And we believe that we'll be a key part of this, but in a fundamentally different way as an organization. And by the way, as a final point, the healthcare cost problem is a major problem in every country around the world, regardless of who pays for it. What's going on in Western Europe and Southern Europe is a fight over the social contract that people thought they had after World War II that is no longer affordable, and their governments are paying for it. And what's going on in the Middle East and China is a stunning fear on their part that they're going to end up with what we've got in the developed countries. So everybody's looking at this issue, everybody's focused on it, and I think the opportunity is here in large part because of a simple act that was passed in March of 2010. So thank you very much for your time and attention. I'll take any questions that you may have. We have microphones up here, and being from Detroit, I cannot be intimidated or insulted. So any question is a good one.
Could you comment on care of seniors in the last year of life as well as mental health issues?
So on July 15th, 2002, I put my son into hospice. He had T-cell gamma delta lymphoma that was considered incurable. And I had lived with him for 1.5 years in the hospital trying to fix it. And in order to do that, I had to admit he was going to die in 6 months and that I could no longer seek curative services. Well, we found a drug in Europe to help feed him. He was starving from his cure. And he graduated from hospice, and he's now a quant at State Street Financial Advisors in Boston, and living a very good life. He was the recipient of that kidney I gave away in 2007, and we get together on Sunday evenings and get the kidneys back together and drink Bud Long Necks. When I got back to work, we changed our end-of-life program. And what we said was, we are no longer going to make you admit you're going to die in 6 months, and we're going to allow you to seek curative services even while you're in a hospice. And because we were afraid of what that would do to our costs. We did it with our self-funded clients. Let Mikey try it, right? And we did it with our self-funded clients, and we were stunned with the results. 89% drop in acute days, 79% drop in procedures, an 80% drop in costs, and feedback from our customers, from our members, that was just incredible. And so now all of our clients get it. And we think that ought to be the standard across the United States. Now, we introduced it to the White House during the healthcare reform debate, and they wouldn't touch it because of death committees, right? Death panels. And so we brought it to IOM and said, why don't you hold a conference? We held the conference, and we haven't made much progress because I think people are afraid to touch it because of the political realities. But we think that's the way to move forward. It's easier for people to do. Yes?
Thank you for your time. I do research in BJ's lab here and sometimes get to work with your Aetna folks, so
Yep.
I'm thrilled to listen to you. So a lot of what you talked about is really exciting and also heavily dependent on healthcare consumerism here in the United States. And we've been receiving our healthcare through employers since World War II. And so this shift to healthcare consumerism is what culturally we're hoping for. I was wondering if you could comment on that and talk about what Aetna and other payers are doing about that.
The shift to healthcare consumerism is unstoppable and inexorable for a couple of reasons. One is that employers have been shifting 50% of the increase in healthcare costs to their employees each year for the last 7 years. And so if you keep that trend going for another 5, employees will be paying half of their healthcare, either through out-of-pocket costs on benefits or insurance, shared insurance premiums. And so when that happens, they're going to say, well, what are you guys doing for me on trend, right? And so we believe it's inexorable. The second thing that's going to happen is that the public exchanges have now freed the minds of health insurance executives around the country to build private exchanges. And what private exchanges will do is create marketplaces for individuals that allow them to get a value equation on benefits that matches their personal lifestyle. So there'll be more offerings, and because there will be more offerings, they'll be able to select with selection tools that we've built and tested, and actually the overall pool's risk goes down. Because people are not underinsured or overinsured, they're insured just right for what they expect for their families. So it's going to be a consumer marketplace, even though the employers may be involved, but I think evolutionary over time, they'll actually sort of disappear and move to defined contribution, and off they'll go. So it's going to happen. It's here. We believe it's here. It's just early in the game, but you can never get too early, get started too early on the change. Yes.
Hi, Mark Zitter. I appreciate your comments and support of everything you're doing. My concern in terms of healthcare costs going up is the biggest chunk of it and the fastest growing, and probably the place with the greatest waste is hospitals. And it's hard to be much of a consumer in the hospital side. Aetna, good example. You're typical at 7, 8, 9% market share in any local area, and it's a very local issue. So how can either the insurance industry or consumers really make a dent in what is the biggest and fastest growing part of the costs?
So the consolidation you're seeing that I showed on that slide, consolidation with physicians, is also happening between hospitals, and systems are getting larger. And so the model of what I call mutually assured destruction, which is we beat each other up in the marketplace until somebody loses or gives up or gets tired, won't work. Because the people that get lost in the middle of that are the consumers, the people who are using the healthcare system. So we need to fundamentally change our relationship. And so our model of infusing our technology and capabilities into their own running of the system will cause them to change that. And the systems that are forward thinking, and we've selected the systems we're working with very carefully to make sure that we have people that will get it right so that we create, okay, I want one of those too over time. Now, the thing that I don't talk about often is the ugly problem that's going to happen 5 to 10 years from now. And that is, we used to, in Michigan, where I grew up, we used to get water in the basement in the spring when it would rain. And so you go downstairs, I got 3 feet of water in the basement. That wasn't bad. It was when the water went away that you had this horrible problem that you had to clean up. Well, when we get through this shift, there will be all this stuff we have left that we won't know what to do with. Capacity. I go up to Blue Hill, Maine every summer. The Blue Hill Hospital. I mean, I can't imagine what goes on in that place and why it's still there. But the people in that community love it. But that place isn't going to survive. And so there are going to be a bunch of places and things and technologies and doctors, particularly specialists, that we aren't going to need anymore. How do we best use them? Well, in emerging countries like China, they are doing everything they can to get primary and secondary care systems up. Quaternary, tertiary care systems are a bridge too far for them anytime soon. So the potential to export our expertise through technology and other means is going to make a big difference, or to get the people here for care. So I think that's going to be how we're going to manage it. But that stuff, all that stuff laying around is going to be the big problem, and I think that's where we're going to see the big public problem. And I think we saw that in the UK a few years ago when they tried to shut down some hospitals as part of their health reform effort.
I can relate to your comments about the upcoming physician shortage, because I was appalled to find that my medical school that I started at 40 years ago, the size of the entering class has not changed in 40 years.
Right.
So my question for you is, can you comment on the article that was in The Atlantic recently, "The Robot Will See You Now," about the coming presence of robots, and also about the model where the decision-making is ratcheted down, and that the physicians are the ones that are just supervising ancillary healthcare personnel?
So I think the second part's probably the more realistic than the robot, but you know, robots sell magazines, right? And so you know, I think the real issue is going to be a new model of healthcare. Today, in a physician's office, the staff works to support the physician in taking care of the patient. In a new model called patient-centered medical homes, the staff all focuses on the patient. And where you have, you know, clinical nurse practitioners, you know, craniosacral therapists, acupuncturists who all do their own thing, and that the physician's use of skills is for the far more cognitive, laying on of hands kind of things. I mean, when's the last time anybody's been to a doctor and the doctor actually touched you? Right? I mean, I have a spinal cord injury, and every time I go see a doctor for follow-up and evaluation, so oh, yeah, I saw your films and I looked at your stuff. I don't need to examine you. So I think the whole shift in the way we treat people in the doctor's office has to happen. And it's going to be this patient-centered medical home, and it's going to be driven by the shortage. Because we can't nearly educate enough doctors in the time it's going to take to get to meet that shortage. Yes, sir.
Yeah, thanks for your comments. Specific question. So policy limits, the removal of policy limits was one of the key functions of PPOC. I'm sure it's kept your actuaries thinking a little bit about the implications. I'm curious about the implications you think as a major national insurer in terms of the removal of annual and lifetime limits, and specifically the experience you had on social media last year on the student health claim.
Yeah, with RG. On the first part of the question, you know, nasty little secret, it didn't cost that much.
True.
Right, so it's been no big deal. You know, I mean, when you put it over a broader population, the cost really isn't there. So I think we didn't see the kind of impact we thought we would see, and quite frankly, it's been pretty good. Now, utilization is really low right now because of the economy and because of what people are paying out of pocket. So I think we have an artificial environment, an artifact of people not using as much care as they otherwise would, which so far we think is a good thing because we're not seeing people avoid chronic care that they need. We're seeing people not getting an antibiotic for a cold, which is all good stuff. So people aren't hitting those policy limits. The second one on social media, so one of my goals in this job, and CEOs are fleeting, I'm the 14th chairman of a 160-year-old company, and we have a very short half-life. The first chairman was around for 20 years, and now you know, we usually last 5 or 6 years. But one of my goals is to reestablish the credibility of corporate leadership in the eyes of the American public. Really tall task. The only way you do that is make yourself available. And as my PR folks over there will tell you, I tell them they can prepare me, they can't protect me. I'm going out there. So I was out on Twitter, and you know, I got engaged with this patient. It was a student. He was, you know, in his late 20s. He got colon cancer, and he had a policy that the university sold that was really cheap. It had a $300,000 limit. So as a student, you think, you know, what are the chances I'm going to hit $300,000 worth of health care? Well, he got stage 4 colon cancer. And he was well through it. So he tweeted me and said, I'm $118,000 over. Why don't you write a check, given that you made $9.75 million last year? And I engaged him. And you know, when I engaged him, all of his friends piled on. And I was in this very intense conversation for about 12 hours while my team, I have a bunch of Twitter reps that work with me now that follow up behind me. They were working out an arrangement with the school to try and get this kid more coverage. And so what we found out was there was 5 other students that had the same problem. They weren't not all colon cancer, but they were hitting their limits. at the same university, right? And so what we did is we had the university pay up premium for each of those 6 people to a $500,000 limit, and then we renewed them at $1 million limit the next year. And then, of course, when the Affordable Care Act kicked in, there was no limit. And we were able to get them covered, and we got it all paid. Now, REG just passed away 2 weeks ago, the end of March, because he was pretty advanced in his cancer. But that is just a typical problem that I deal with a dozen of those every day. Not as big a case, but cases now that reach out to me and want me to help, and we solve most of those problems. And we also say no to some people who have, expectations beyond it. Now, where's this all headed? I would argue that if we do population health management right, we don't need benefit plans. Now, you have one of those here in California. It's called the SCAN Health Plan down in San Diego, and it's called a social HMO, where we provide all the benefits necessary to keep people healthy. Follow-up cab ride to the office after a discharge from congestive heart failure, diapers for mothers of 3 who can't afford them, all toward making this investment in keeping people healthy. So if we make that leap, and I may either be on the beach or taking a dirt nap by the time we get there, but that is sort of the evolution we need to move to, where the community gets together and say this is what we should provide in the way of services to people to keep them healthy. Yes?
So I look at things from a little different perspective.
That's okay.
How do you add the liability factor into the conversation, and what weight do you put to that when you speak to, for instance, the nurses or staff taking care of a patient instead of the physician, and then some of these personalized apps? I wonder how that's being factored in from your perspective.
Well, on the latter part on the apps, we do spend more time with the FDA than we would like. And we try to stay this side of having to be regulated as a medical device, but we're getting closer with each evolution that we make. And so we know where that line is, and we're trying to stay on this side of it, but I think we'll eventually have to cross it. And we're working with companies like Medtronic to connect to their pacemakers to follow arrhythmias and to report those into our clinical decision support systems and get the information to the doctor before the patient even knows they've got a problem. And all of that's going to drag us into the FDA compliance problem. And we'll have to get approved. So we're not quite there yet, but we're on this side of it. On the liability side of things, we've been dealing with liability, and we have a list that would probably impress you of cases going on in any given day. And I think we handle those well. And part of handling it well is really to be very honest with the people we're dealing with and be very transparent about what they're getting and not getting. And I think that works in the practice setting as well. Because people often don't get explained what's going on. They don't get the right set of information to make good decisions, and they have different expectations than they should have and want to blame somebody. They get angry. And I'm probably abnormal. I worry less about malpractice liability as a driver of healthcare costs than all those other things up on that list. And so we could solve those, we can then get at malpractice liability. But all those other things I had on that circle of $750 billion are far more significant than malpractice right now. Okay?
Hi. As we move from volume-based care to value-based care, how do we really measure the quality of care, and who is the arbiter of that quality?
So the quality of care is going to be in the eyes of the person receiving the care. So when I broke my neck, I have severe neuropathy. My left arm feels like it's burning on fire all day long, even at this moment. And the only way, and I was given 7 different narcotics, and I walked around like Charlie Brown in the Peanuts commercial, when his mother would talk, wow, 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 the whole world sounded like that to me. And I knew I wasn't going to be a highly functioning human being. I went and got cranial sacral therapy, acupuncture, I carry my own needles now and do it myself, and I use yoga and meditation to manage my pain every day. I take no pain medication. Now that is outside the norm of what we would call healthcare, right? But for me, that's what makes me healthy. And so I think this definition of I decide what's healthy for me versus what some arbitrary set of metrics decides what's healthy is the most important thing. And so getting that into people's hands and allowing them to make that decision will make them happier and healthier. Now, how do we pay for that? And I think we need to, and so back to my number of, what if we just said no more increase in healthcare costs? What if we said 2.7 trillion is enough? All of you figure out how to spend that differently. I think we could do that. We've got governance issues and a whole bunch of other issues, but I think we could figure out how to do it differently if we just kept the budget flat. And so I think that's moving it to outcomes-based. Are people healthier? Are they happier? We should actually measure people's happiness with the healthcare system. You know, everybody loves their own insurance company but hates insurance companies, interestingly enough. And so I think this notion of I feel healthy and I'm happier as a result of it, and I'm productive and I have economic sustainability because of that productivity should be the definition of it. Long way to go, but that's where we ultimately need to head. Yes, sir.
Thank you, Mark. In this inevitable world of consumerism, in every other aspect of being a consumer, price transparency is a foundation, it's a fundamental. Can you talk about what you see as the role of price transparency, and in particular, what Aetna is doing to support it both internally and in support of others who are trying to pursue it?
So we have the top 30 prices of what we pay to every provider in the United States on our website for any member who wants to look at it. Less than 10%. We have a member payment estimator tool that allows you to auto-adjudicate your claim on your smartphone at the doctor's desk and settle up with your provider. Less than 10% use it. So there's something fundamentally wrong with people's, so this CarePass platform is really about changing that, where I go to a place where the ecosystem supports me in interacting with the healthcare system versus having to go to this app to find my doctor, this app to find out how much it's going to cost, this app to pay for it. It needs to be in a common ecosystem like that Google shopping experience where Google Shopper popped up and then Google Maps popped up all at once without me having to do it. And so I think that is where we need to go next in order to get it done. Transparency will be critically important, and people are more and more asking for it. Right now, we're all over the map from a transparency standpoint. At Aetna, we have the real prices we pay, absent the benefit determination, which we can now do as well. But there are reference-based pricing, which I don't think works really well, and people sort of look past it. But as they're pulling more out of their pocket, they're going to start asking that question. The best thing to do is move away from that model of fee-for-service to bundled payments, and I think that'll be the step that'll make that transparency go away, or that issue anyway. Yes?
That actually leads quite nicely into my question, which is if we're focusing on, you know, if consumerism in healthcare is a wave of the future, it could be argued that overtreatment and overutilization could be somewhat driven by this consumer demand of healthcare services. Mm-hmm. And a lot of that demand is sometimes supplied or driven by physician decision-making. This needs to happen, this test needs to be assigned, which could be considered one of the reasons for rising costs. So what role do you think physician payment incentive models, and what role does Aetna play in driving physician behavior and decision-making in the future?
So I think it matters, and I think the juxtaposition of member out-of-pocket, physician reimbursement, and the medical management model, which includes transparency and advice and all those other sorts of things, is going to really create a behavior change. But it needs, again, to be simple. It needs to be like falling out of bed. And so, you know, I think that model is where we need to go. But I don't. Here's the problem. If I agreed that I was going to pay 90% of your next car, what kind of car would you get? You get a car 10 times the amount you could afford to pay for a car, right? That's the economic principle. That's the problem we have in the healthcare system. If I only have to pay 10% of my costs, then anything that I can afford up to that 10%, the 90% somebody else's nickel, I'm okay with that. And so I think the shift in benefits is going to create a change, but it really needs to be informed by data, and it needs to be simple to get. I think ultimately, I would argue, and what we're doing with some of our major health systems is creating budgets and saying, here's what we think healthcare costs on average across the population should be. We'll take half the risk, you take half the risk, and we'll give you all the technology to do that. That's what we're doing. And we actually have some health systems that are saying, we'll take 80% of the risk because we so much believe in our ability to better manage, better governance, and better manage our population that we'll take 80% of it. And they're winning so far. Thanks. Hi.
Hi, Mark. I guess this is the last question. My question for you is around how do you create a more educated consumer in a marketplace where they're going to be directing their healthcare decisions, specifically in terms of the level of care and in terms of the site of care, so that they utilize the system appropriately?
So I think trying to educate everybody on how the healthcare system works in a level of detail isn't going to work. Sorry to say. And the reason is that unless the amount of information I can gather is immediately available and that when I act on it, it has an immediate response, I'm not going to pay attention to it. Let's look at my favorite topic, obesity, right? 62% of the American public is overweight. You know, more than a third of the American public is obese. And in our population of 37.5 million people that we manage, 34% have a chronic disease, which drives 75% of our healthcare spending. And of those people that have a chronic disease, more than half of it is related to their body weight. So in 2009, we spent billions of dollars in this country to prevent the swine flu from killing 10,000 people. And we lose that many people a week to obesity. Now, if I were to have that conversation and say, put the cookie down, because 25 or 30 years from now, you're going to have metabolic syndrome, which is highly correlated to waist size and to fasting glucose. And that means you're going to have a 60% chance of being diabetic, which is going to cost you money, dramatically impact your lifestyle, cause you to maybe lose sexual function and a whole bunch of other things, limbs, and you ought to be worried about that right now. People yawn and go, are you done yet? Because I got a party to go to. And so I think that is our problem. And that is the single biggest, it is a pandemic across the United States, this disease. And it's a pandemic around the world. And we're not doing it. Saudi Arabia has the highest incidence of diabetes of any population in the world. And you know why? 50 years ago, they found oil. And being overweight and having somebody else do your work and eating really good food was a sign of wealth. And when I talked to one of our partners from the Oleon group in Riyadh about why is this happening, she said, Mark, 2 generations ago, my grandfather was a Bedouin tribal leader starving in the desert. And now we've arrived with the highest diabetes burden in the world. So I think that, so health education on those issues aren't going to work. We need to make it real easy for people to stay fit. So I've got my, my up band, and I put it on February 7th. I've lost 15 pounds since then because I'm a data geek and I look at it all day long. How many calories have I consumed? How many have I need to go for a walk? Instead of that last glass of scotch, I'll go for a walk. And that's what people need to see. It needs to be immediate. It happens now and you're interacting with it now. Thank you so very much for your time and attention.